So we'll continue talking about fluconazole, the antifungal, the 150 milligrams capsule. So let's move on to the side effects or unwanted or adverse effects of the drug. So firstly, there is increased risk of exfoliative skin disorders, including Stevens-Johnson syndrome, and also agranulocytosis and thrombocytopenia. Most of the adverse effects with fluconazole are related to the gastrointestinal tract, and this includes abdominal pain, diarrhea, flatulence, nausea and vomiting, and also taste disturbance. Other adverse effects include having headaches, dizziness, leukopenia, thrombocytopenia, hyperlipidemias, and also raised liver enzyme values. So we have headache and dizziness, the CNS effects, leukopenia, thrombocytopenia, effects of the blood, hyperlipidemias, endocrine effects, and also raised liver enzyme values. And serious hepatotoxicity has been reported in patients with severe underlying disease such as AIDS or malignancy. And rarely we see anaphylaxis and angioedema. So angioedema and anaphylaxis have been reported, but rarely. So as mentioned in the precautions part, so skin reactions are rare, but exfoliative cutaneous reactions such as toxic epidermal necrolysis and Stevens-Johnson syndrome has occurred, and this is more common in patients with AIDS. With regards to the pregnancy category, fluconazole should not be given to patients who are pregnant and also patients who are lactating. So nursing mothers should not take fluconazole tablet, 150 milligram one. Okay. So let's go back a little bit and go to the basics. Some basics about fluconazole. How does it act? What is the actions, and what is the pharmacology, the PD pharmacodynamics of the drug? So fluconazole is a triazole antifungal agent. So it is a potent and specific inhibitor of fungal sterol synthesis. So it is a specific inhibitor of fungal sterol synthesis. So it's a specific inhibitor of sterol synthesis. It inhibits the synthesis of sterol. So based on the models in animals, activity has been demonstrated against opportunistic mycosis, such as infections with Candida species, including systemic candidiasis in immunocompromised animals with Cryptococcus neoformans, including intracranial infections with Microsporum species and with Trichophyton species. And in animal models, the drug has also been shown to be active in animals with endemic mycosis, including infections with Blastomyces dermatitis, with Coccidioides immitis. It's also been useful in intracranial infections and also in animals with Histoplasma capsulatum, in normal and also immunosuppressed animals. there have been reports of cases of superinfection with Candida species other than Candida albicans, which are inherently not susceptible to fluconazole. Example, Candida krusei. So such cases may require alternative antifungal therapy. And fluconazole, another pharmacodynamic thing is that it is a highly specific for fungal cytochrome P450 dependent enzymes. And fluconazole 50 milligrams daily given up to 28 days. Given up to 28 days, which is about a month, has been shown not to affect testosterone plasma concentrations in males or steroid concentrations in females of childbearing age. And fluconazole 200 to 400 milligrams daily has no clinically significant effect on endogenous levels of steroids, and it has also no significant effect clinically on ACTH stimulated response in healthy male volunteers. So previously we were talking about animals, now we're talking about humans, studies in human beings. And interaction studies with antipyrine indicate that single or multiple doses of fluconazole 50 milligrams do not affect its metabolism. So that's about it for the pharmacodynamics. Now we go to the PK, pharmacokinetics. So fluconazole is well absorbed after oral doses. Bioavailability from the oral route being 90% or more compared to the IV route or route. Peak concentrations are needed within 0.5, not 0.5 or 0.5 to 1.5 hours of oral administration. And plasma concentrations are proportional to dose. So plasma concentrations will be proportionate to the dose that is given. So steady state concentration are needed by day 4 to 5. So it's achieved by day 4 to 5 with multiple once daily dosing, but may be obtained on day 2 if a loading dose is given. So that's the importance of a loading dose. If you give a loading dose, then you can achieve the steady state faster. So the drug is widely distributed throughout the body with good penetration into the cerebrospinal fluid in patients with fungal meningitis, which is approximately 80% of the corresponding plasma levels. And also the eye and peritoneal fluid levels. So the apparent volume of distribution is close to that of total body water. So concentrations in breast milk, joint fluid, saliva, sputum, vaginal fluids, and peritoneal fluid are similar to those achieved in plasma. And that's one of the reasons why we will not give patients while breastfeeding. We don't recommend or we don't allow, so it's contraindicated for patients who are breastfeeding to take fluconazole oral. And the plasma protein binding of fluconazole is low, about 11 to 12%. Clearance is mainly by renal excretion. It's cleared mainly by it's cleared or eliminated mainly by renal excretion. And about 80% of the administered dose is excreted unchanged in the urine, and about 11% as metabolites. So the elimination half-life of fluconazole is about 30 hours, and this will be increased in patients with renal impairment. And this is a drug that is removed by dialysis. So next we talk about the overdose, OD. So patients who overdose with fluconazole and patients with, we have seen that patients with HIV and given overdose of fluconazole, not given, I mean they took or they overdosed themselves, they OD themselves, so they developed hallucinations and also exhibited paranoid behavior after ingesting a huge amount, which is 80 to 100 milligrams of fluconazole. So how many tablets is that? So many tablets, okay, more than maybe it's about 100 tablets, near 100 tablets. And the condition of having hallucinations and being paranoid resolved. So it will resolve within 48 hours. The treatment is symptomatic, so supportive measures, and if necessary we can do gastric lavage, and only giving symptomatic treatment might be adequate. So fluconazole, as we mentioned in the PK segment, is largely excreted in the urine, and forced volume diuresis would probably increase the elimination rate. And a 3-hour hemodialysis session has been shown to decrease the plasma levels by approximately 50%. So interactions with other medications. So with anticoagulants, number one, anticoagulants, bleeding events such as bruising, epistaxis, GI bleeding, hematuria and melena have been reported, and also increases in prothrombin time in patients receiving fluconazole concurrently with warfarin. So you can see bleeding, there will be bleeding potentially with anticoagulants such as warfarin with fluconazole. And prothrombin time in patients receiving coumarin type anticoagulant should be carefully monitored. Number two, azithromycin. So there was no significant PK interaction between fluconazole and azithromycin. As with benzodiazepines, short acting. Following oral administration of midazolam, fluconazole resulted in substantial increases in midazolam concentrations and also psychomotor effects. So the concentration of midazolam went up, and as a result we see psychomotor side effects. And this effect on midazolam appeared to be more pronounced following oral administration of fluconazole than with the fluconazole given IV somehow. If concomitant benzodiazepine therapy is necessary in patients being treated with fluconazole, so we should consider decreasing the benzodiazepine dosage, and the patients should be appropriately monitored. Okay, we'll see you in the next series for fluconazole.